All right, so it's 1 o'clock. We're going to start. Thank you, everyone, for calling in to attend our LGBTQ friendly practice webinar. I am Patrick Chu. I'm the Policy Initiatives Lead here at ARNBC. And I'd like to introduce our two presenters today. We have Derek Seaton and Zach Mayeshin. Derek comes to the topic of LGBTQ-friendly nursing largely due to his personal experience as a transgender person himself. As a recent student at the UBC School of Nursing, Derek participated in a faculty student group focused on trans-friendly nursing practices and co-taught a resulting class with some of his fellow participants on trauma-informed care. In his current practice at the BC Cancer Agency, he has worked with various LGBTQ patients and families and has continued to think carefully about his resulting practice as a nurse, drawing on his dual experiences as a patient and a nurse alike. Though his current nursing work does not speak to LGBTQ care as a specific topic, Derek feels strongly about his utility as a potential caregiver, advocate, and ally to LGBTQ patients. He hopes to contribute to building conversation around trans issues, particularly in the larger nursing world. Zach began his career in clinical practice, where he practiced in multiple areas, including med-surg, emergency intensive care, vascular access, and outpost nursing. He obtained his NP education in 2008 and has had a primary health care practice for the past 8 years in a West Kootenay family clinic, providing primary health care to the general public with a focus on marginalized populations. Practicing in a rural area of BC, Zach is aware that marginalized groups have a tougher time than those in urban areas to find judgment-free and welcoming care. He has had the honor of developing such a practice where everyone in his community can feel welcome, and in the past year has added transgendered care to his practice, including but not limited to hormone therapy and surgical assessment. Zach is currently the president of the ARNBC. So the presentation will be about 40 to 45 minutes. We're going to leave about 15 minutes at the end to respond to any questions or comments. Everyone is actually muted right now on the teleconference line just to prevent any excess noise. If you do have questions, you can see on your right-hand side there's a sidebar, and there's a tab for questions. So if you type your question in during the webinar, we'll keep track of it and we'll read it out loud at the end, so either Zach, Derek, or whoever's on the line can comment. And for those who couldn't attend this webinar, we will be recording and archiving it on our website. So if you have colleagues who would like to see this on a future date, please direct them back to the ARNBC website. So I'll turn it over to Zach.
All right, thank you, Patrick. And so, yes, I'm broadcasting from the West Kootenay right now, so hoping this comes in clear and let me know if it's not. So we'll just advance to slide 2. And yeah, I'm always mindful of how I personally, and I think it's probably a more general fault that we tend to talk more than we mean to, so I'm going to try to be succinct with my bits here so we have room for questions. Can we advance to slide 2? There we go. Oh, I guess I could too, actually. I have to think. Okay, so what are we doing here? So yeah, our goal here is to improve nurses' ability to provide culturally appropriate care for lesbian, gay, bisexual, transgender, queer, or questioning people. What we hope to accomplish is to help demystify some of the terms around sex, gender, sexual orientation, and gender identity, which are all discrete areas. We want to identify key dates that have helped shape the current landscape of LGBTQ rights and give a brief history. We'll identify the current issues that LGBTQ people face within the healthcare system, as well as health issues that they may be more vulnerable to. And finally, we'll identify ways in which nurses and all healthcare professionals can provide appropriate care to LGBTQ plus people. Advancing, there we go. So here we have a brief history of time. So once upon a time, Canada was not as great as it is now. So there's been quite a few significant changes in the last 60 years, but before that point, homosexuality was actually criminalized. But in the beginning of the 1960s, the LGBTQ community in Canada has seen steady gains in social acceptance and equality. all hard fought. This began actually in 1967. Pierre Trudeau, then as Justice Minister, introduced a rather large omnibus bill that sought to decriminalize homosexuality, and it also had other important things like decriminalizing contraception, and there's a few other things in that important bill. It didn't actually pass in '67, but a couple of years later, when he was Prime Minister in 1969, Bill C-150 passed, and homosexuality was no longer a criminal act. And he famously said that, am I paraphrasing right, that the state has no business in the bedrooms of the nation, which I think is quite appropriate. So following this, the gay liberation movement began in the 70s, and we saw some of the first protests for gay rights in Ottawa and Vancouver. As I said, homosexuality was decriminalized under the criminal code, and further, and relevant to our conversation, it was removed as a disorder from the DSM in 1973. So while LGBTQ rights continued to advance with the number of legal victories, there was ongoing discrimination and police harassment through the 80s. Notably, in 1981, in Toronto's, Canada's version of the New York Stonewall raids, there were violent bathhouse raids in Toronto, which saw hundreds of gay men arrested 35 years ago. During the 80s, we also saw sexual orientation recommended by the Canadian Human Rights Commission to be added to the Human Rights Code. We saw the emergence of the HIV/AIDS epidemic and the development of AIDS service organizations which offered care to individuals living with HIV/AIDS. AIDS Vancouver was the first organization in Canada to do this work. And then also during the 1980s, Red Cross, which ran Canada's blood donor system, implemented a new rule at that time that any man who has had sex with a man even once since 1977 could not be eligible to donate. Since during the 1990s, we saw a federal court ruling which lifted the ban on gays and lesbians in the military. The Supreme Court ruled that gays and lesbians facing persecution based on their sexual orientation in their countries of origin could apply for refugee status. And the Supreme Court also ruled that Section 15 of the Charter, right to equal protection and equal benefit of the law without discrimination, would also include sexual orientation. And it added to the Canadian Human Rights Act in 1996. And in 1999, the Supreme Court ruled that same-sex couples must be afforded same rights as opposed-sex couples in common law relationships. The advancements continued into the 2000s when the federal government introduced Bill C-23, which gives same-sex couples who have lived together for more than 1 year the same rights and access as other common law couples. And Bill C-38 became federal law, which endorsed these rights. Canada became the 4th country in the world to allow same-sex marriage as an entire country. Recently, in the 2010s, issues around trans people have been rising and gaining more attention due to a high incidence of bullying. Gender identity is currently not mentioned in federal legislation, but there is a bill, C-279, which would amend the Canadian Human Rights Act and Criminal Code to include gender expression and identity and protect transgender people from discrimination. It is currently undergoing a second reading in the Senate. Transgender activists are also fighting to make it easier to change gender on official documents without the need to undergo gender reassignment surgery. And closer to home, of course, just a few months ago, BC recently amended our Provincial Bill of Rights, which now includes gender identity and gender expression. So as you can see, we've come a long way, but despite these gains in social acceptance and legal wins, there does continue to be issues impacting health, seeking behavior among LGBTQ people, and the quality of care they receive. There we go. So, why should we care? Because we're nurses. So, I mean, really, our scope as nurses within our profession is societal and population health as it extends to all of our citizens. So, in a general way, of course, this is relevant to us. And there are several aspects or touch points in particular that are relevant to us. So if we follow this little diagram here, we look at conscious and unintentional discriminations, assumptions, lack of knowledge and skills among healthcare providers. And some of this, I really like how this points out conscious or unintentional discrimination, because, I mean, obviously, homophobia and transphobia can exist amongst nurses as can anywhere. However, there's that understated side of things, and I mean, I'm speaking as a white male cisgendered heterosexual, reasonably well-educated, well-income type of person that doesn't face a lot of the discrimination of many other groups. And so just the mere fact of growing up and living in a society whereby inequities exist and privilege exists, I don't know, I guess I'm speaking personally, one can, or my own personal opinion, but one cannot help but be subject to the discriminations of our society. And so it is a daily effort, a conscious effort to overcome that. And so personally, I'm mindful of that and the need to address that head on. And then if we follow the arrows here, there are fears among disclosure and coming out and discrimination amongst our patients themselves. And so all of that together can cause a reluctance and a reticence to access safe and appropriate care due to previous discrimination or stigma. And of course, we know that timely access to care is important and prevention is important, and if the treatment is delayed or not sought at all, then things get worse. And so health outcomes and well-being in general suffers. And so specifically, because we are nurses, we like the evidence. I'll just go over a few well-documented negative outcomes that affect this population. So first of all, we do note that there's higher rates of depression, suicidal ideation, suicide, anxiety, and stress compared to those who are not LGBTQ. In fact, the risk of suicide amongst trans and queer youth is 14 times higher than the general youth population. And while there are many factors that contribute to this, a big contributor to this includes external and internal stigma, discrimination, and experiences throughout the lives of LGBTQ people. Specifically, trans people experience higher levels of harassment, violence, and discrimination compared to lesbian, gay, or bisexual people. And the stress associated with this also plays a part in higher rates of substance use and risky sexual behavior. We can also look at diet and weight and body image. Disparities exist, and issues in diet, weight, and body image are often different than in heterosexual or cisgendered people. Gay and bisexual men often show higher rates of dieting and excessive exercise compared to straight men, as well as body dysphoria. And lesbian women show higher rates of being overweight and obesity. We look at substance use. Research has definitively shown there are higher levels of use amongst LGBTQ population compared to those who identify as straight, and that includes tobacco and alcohol. There is also some literature that speaks to a history of the lack of a non-bar space to socialize. And so if the only safe space you have is within a bar, then, as they say, if you spend too much time in a barbershop, you get a haircut. I don't know why I threw that analogy in, but anyway, that's probably part of it. As well as poverty and homelessness, some evidence in BC is pointing to 1 in 4 queer and trans youth in BC face homelessness or imminent homelessness due to being forced out of their homes due to a severe family conflict. Queer and trans youth are twice as likely to live in unstable housing, and 29% of trans people reported being turned away when attempting to access shelters. Many existing youth shelters or housing programs also do not cater to LGBTQ needs. And if we speak to violence, 1 in 5 trans people has experienced physical or sexual abuse, and 1 in 3 has experienced verbal threats and harassment. So if we didn't need any hard data to support our efforts and our priority to make a difference here, I think that the above certainly points to it. So I'll turn it over to Derek for the next section.
Okay, thank you. Yeah, what we want to do now is just move through some basic definitions and concepts to start with, and then move on to focusing, I guess, a somewhat greater conversation on the issue of transgender healthcare issues in particular. So our first slide sets up a distinction between biological sex and gender. Many of you will be aware, of course, of these distinctions, so I hope you'll bear with me. And then we want to move on to discussing sexuality as well. In terms of sex, we generally use the word sex to refer to one's biological sex. One's biological heritage is male, female, or intersex, which of course is determined by the obvious: one's sexual and reproductive anatomy, chromosomal makeup, the way in which chromosomes drive hormonal function, and so on. As we are aware, of course, you are usually assigned to either male or female, or you may well be assigned to the biological distinction of intersex, which which biologically may be distinguished by any variety of features. One write-up about it suggests that biologically intersex people may have, quote, external genitalia which do not closely resemble typical male or female genitalia, or which have the appearance of both male and female genitalia, or they may have the genitalia of one sex and the secondary sex characteristics of another sex, or they may have a chromosomal makeup that is neither XX or XY, but may be a combination of both. So we can see there that it really covers quite a wide variety of possible characteristics and experiences on the part of the intersex person. In opposition to biological sex, we also talk about gender implying a socially constructed gender or sex-based role, as well as an internal sense of one's own gender too. So this includes ideas of gender assignment, and we'll talk about some of these terms later, gender roles, gender attribution, and gender identity. Most people, of course, those who are cisgendered, meaning those who are who inhabit in a social sense the same gender role as they occupy biologically. For most people, of course, their biological sex and their socially constructed gender correspond, whereas for trans and gender variant people, they do not necessarily, although in a wide variety of ways for different people. And then again, for intersex people, how they deal with and feel about their own gender identity in a world where, of course, the assumption is that one is either simply male or simply female, is also a complicated issue, and each person comes up presumably with their own solution or solutions. The next slide deals with issues of sexual orientation as well, just to set up a distinction between that and then the issue of sex, biological sex, or socially constructed gender. So there's a variety of definitions here, many of which, of course, we are more than familiar with: homosexual versus bisexual versus heterosexuality. In all cases, of course, what we're really addressing is the person's experience of and pattern of affection and or sexual attraction and engagement. Terms that are probably less familiar would be someone who identifies as asexual, that they are not sexually or romantically active and or sexually or romantically attracted to other people. People often respond to this statement of identity by saying, oh, well, you just haven't met the right person yet, or some other kind of dismissing statement. But I think it's important to know that people who identify as asexual are really speaking of a very considered statement about their experience and self-understanding. And too often it's simply dismissed as an absence, not as an actual statement of identity. Then the issue of people who are pansexual, to me this is a somewhat less familiar term, but speaks, I think, to the idea that people might be attracted to people of any gender, irrespective of gender at all. Really, that therefore gender itself is not a part of their category of attraction or sexual interest, and instead how they construe the idea of desire really is based on other ways of looking at people. I think it's also important to think through how none of these categories really are fully mutually exclusive. certainly not necessarily within one person's life. And so we like to set up these distinctions. They are descriptive, but they're not by any means definitive. And then finally, I think it's worth mentioning the two-spirited designation, which the people in some Indigenous communities use, specific to Indigenous cultures, which speaks to a sexual, gender, cultural, and or a spiritual identity. So sometimes if a person claims that they are two-spirited, you can consider that they may be thinking in a way that makes that designation interchangeable with gay or with lesbian or bisexual or trans, but it doesn't necessarily translate. It has different cultural information in that idea. And so I think, for one thing, at the least, we can see it doesn't necessarily distinguish between alternate sexualities and alternate gender identities. So at the least, we as nurses really need to listen very carefully to what a person is telling us when they say they're two-spirited, and not to assume that we automatically know what they mean by that. We also have this gender-bred person. My daughter tells me she has this on the wall in the cafeteria at high school too, and she made round fun of it. I'm not sure in what way, but anyway. And it summarizes some of the other issues concerning particularly gender roles and so forth. Very quickly then, so, it speaks of gender assignment, which refers to the gender that we are assigned at birth, based presumably on biological features. Gender roles, of course, refer to the various expectations of how we behave individually or in groups based on that presumed assigned gender. Gender attribution is the process of how others recognize or view another person's gender, identify them as male or female. Whereas gender identity may or may not coincide with any of these above gender assignments, roles, or attributions, and involves one's internal or psychological sense of oneself as male, female, both, neither, in between, and so on. And then finally, gender expression refers to how you outwardly show your gender, how you dress, your hairstyle, behaviors, really the ideas of masculinity, femininity, or androgynousness, or other things. And then as far as particular gender identities, the language for particular gender identities, we note, of course, that cisgender is used for people whose bodies, as it were, and sense of personal identity correspond in terms of the gender that they were assigned at birth. Trans people, transgender, is described as an umbrella term that describes a wide range of people whose gender identity and or expression differs from conventional expectations based on their assigned biological birth sex. Umbrella term, I think I need to explain a little bit that there's really an extraordinary multiplicity of language out there and a continually growing vocabulary around people who broadly might be categorized as transgender. And so we use trans or transgender or trans with an asterisk, actually, oftentimes just after it, to try to imply both this broad idea of alternate genders, gender variants, and also to try to recognize at the same time that different people, though, will use very different language about themselves in regards to just how they position themselves in a gendered sense. We do have, of course, the words trans man and trans woman, which in both cases it involves an individual who identifies as trans as opposed to as a man or as a woman specifically. And a trans man, of course, identifies with the masculine or the male. The trans woman is a trans person whose gender identity is female or feminine. But again, I think we need to be aware that there's an extraordinarily large array of words out there, not included here, that go well beyond some of these basic terms. And I think, again, the thing is simply to be aware that you might hear these words, you might need to inquire what is meant by them, and of course to respect what you're hearing when you're being told how the person identifies themselves. As well, I guess it's worth saying we're all very worried about pronouns and language in general around trans issues. I should say all of us, and that includes trans people, and certainly people, all of us nurses as well, I would say we're almost all bound to get it wrong some of the time. So it's okay, relax. Sometimes if you don't know what words to use, you want to listen well to what the person is telling you. You want to ask, if you are not sure what words to use, to refer to them pronouns, other ways that they might describe their gender identity. Try hard to use their own words that they use for themselves and have respect for the distinctions they're trying to make. But if you make a mistake, and as I say, you almost certainly will, I do a lot, don't make a big deal of it. Just apologize quickly and move on. And you probably don't need to apologize repeatedly. You don't want to make a big deal of it. Okay, so and then a few other terms regarding gender identities. There's also this word pangender. I'm less familiar with that, multigender or omnigender. I've heard it here more often. I hear such things as non-binary, or genderqueer, or gender fluid, and I think they all cover a similar territory, if not identical, which implies someone who says that their gender is neither male nor female, may encompass both or all genders, excuse me, and so on. So again, just to highlight that the whole discussion around gender these days in particular is trying to break out of a stereotypical male or female binary opposition, and there's a lot of people out there who identify with in ways that are beyond that stereotypical opposition. We've already discussed two-spirit as well as an Aboriginal designation, which can include what we would call trans identities. Finally, transsexual. This isn't a term I don't think that's very favored anymore in the trans community. It implies someone who has transitioned sort of definitively from male to female or female to male. Again, it inscribes that idea of the binary opposition and the sort of rigorous categories that are, completely separated from each other. The word tranny also, too, is not very well liked, I think. And it assumes a kind of bodily concept of a complete transition from one gender to the other. I think it's important to note that many trans people these days don't elect to have all possible hormonal or surgical interventions, may not have had any for that matter, in order to completely correspond with the gender they identify with. And so you can expect to encounter a wide array of bodies out there, as it were. And I can talk about how I define myself in this regard if people are interested in it as an example. I'll leave that to later if you're interested. In any case, then, medically speaking, I'd also like to highlight in particular the phrase gender dysphoria, because this is one of the medical definitions that surrounds the experience of transness. And it highlights the discomfort or distress that's caused by a discrepancy between one's gender identity and the sex that you are assigned at birth. So it's a diagnostic designation. It's described in the DSM-5. Earlier versions of the DSM focused on the idea of gender identity as a problem, and the diagnosis was that there was something non-normative about your gender identity. Now the DSM-5 focuses on the idea of dysphoria, so in other words, distress, as the diagnosable issue. So you could be someone who's gender variant, but if you don't suffer the actual distress that's often associated with it, then you wouldn't necessarily be identified as having gender dysphoria. So the disorder is meant to be a description of something with which a person might struggle. It's not a description of their actual identity. Again, I should add, I think that lots of trans people struggle with this idea of a diagnosis in general, whether it's about an inherent dysfunctional identity or about dysphoria. In BC, it is necessary to get a diagnosis in order to receive publicly funded access to transitional treatments like hormones or surgery. But many people are very resistant to that process, and really, it does highlight the question as to whether transgendered experience really can be defined so exclusively in medical terms. It has a medical component, but there's just so much more to it. So do we need diagnosing? I'm not sure. In any case, then, finally, we need to move on, in particular, of course, to the relevance of all of this to nursing. So the question is, of course, as nurses, how can we improve the way we provide care to LGBTQ people? Well, my approach to this question isn't so much to offer definitive solutions, but in particular, I'm interested in raising some questions about what areas of nursing practice are affected by the possible presence of trans patients, and the kinds of questions that we need to be thinking about and being prepared to contemplate if and when we encounter trans patients or clients. So I want to also mention the extraordinary lack of information that's out there to access. If you're looking for research on transgender nursing care, there's very little out there, and it really seems to me that there's really just two primary kinds of articles that one finds. Either you get a very broad call for awareness of transgender patients in nursing practice and a discussion of the effects of stigma on trans people, especially youth, which is great and is very much a needed thing. But it kind of amounts to a basic call to just be nice to those people, which is great, but doesn't get you very far as to what that actually means in detail. And then the other kinds of article one most often encounters is a basic summary of the medicine involved in the process of transitioning specifically from one gender to the other, so the hormones and the surgeries. Again, this is good to know about, particularly if you're involved in that element of transgender healthcare. But there's an extraordinary lack of attention, and to my knowledge, there's virtually no research on many of the other possible questions that might arise. So I want to just give a quick list of what some of these kinds of issues are that have occurred to me as questions. And for the most part, I don't know the answers. But for example, in the terms of basic hands-on nursing skills, if you consider an inpatient setting, just basic things like how to catheterize somebody who's female to male or male to female. If they've had bottom surgery, which is to say genital surgery, as opposed to top surgery, which is surgery to the chest usually, and then there are still other surgeries that they might have had. But if they've had bottom surgery, how do you insert a urinary catheter in somebody who's had phalloplasty, that is to say the construction of a penis, or vaginoplasty, which is the construction of a vagina? If a woman has had vaginoplasty, will she still have a prostate gland, for example? Is the route in the internal route of the catheter and the distance to the bladder the same for a trans woman as for a cisgendered man? And again, how about trans men who've had a phalloplasty? Well, to my knowledge, there really is no nursing literature out there about these basic kinds of issues. I also wonder about how the implications of other surgeries on broader medical care. What do we need to know about chest surgery and how it might affect other elements of medical care in that area of the body? What do we need to know about the effects of exogenous hormones, so estrogen or testosterone, on a person's health risk factors, on possible treatments, and so on? Does estrogen therapy, for example, increase a trans woman's risk of getting breast cancer? And what would her treatments be different if she did have breast cancer? I also do want to highlight, as I started to mention, trans bodies, that the kinds of bodies you might encounter in healthcare when you're dealing with transgender patients might well have quite a wide variety of features and somewhat unexpected to you. You know, you might have a trans woman who has breasts and a soft voice, but also has a penis. Maybe she still needs prostate examinations. She may or may not ever intend to have an operation to her genitalia, and we should not assume that she will. It also may be that the language she uses around her body parts can be rife. Some trans folks are very uncomfortable with the conventional words for body parts that they consider not to be appropriate to their own sense of bodily identity. And so, again, it's important to let trans folks lead the way in terms of the language they use for body parts with which they may be fairly uncomfortable. I also started to mention risk factors and healthy life choices. As far as someone, let's say a trans man on testosterone, should he be being given the advice that a cisgendered male would get regarding, let's say, safe levels of alcohol consumption or daily vitamin and nutrient requirements? Or is he more like actually a female, let's say, in body size or etc.? And I have no idea the answers to these. I don't know what I should follow myself, to be honest. There's also an enormous questions around safety and privacy. These are huge issues for trans folks. They constitute a large part of the questions that trans folks have around whether they can or should or are able to access health care of any sort. I've had the experience in an ER of having to announce repeatedly behind a thin curtain where there's people on the other side who can certainly hear I've had to announce repeatedly that I'm transgendered. These are the body parts I have. These are the ones I don't have. These are the hormones I'm on, and so forth, without any certainty that the person behind the curtain, might not have extraordinarily strong and negative feelings about there being a trans person near them, and not knowing, therefore, whether I am actually, have a basic safety from verbal or physical violence. This also may be true of patients in multi-patient rooms. If a trans patient is in a hospital, can they be assured of a private room for the sake of safety and privacy? Will nurses at the nursing station convey information about a person's trans status with full awareness of the need for confidentiality and safety? I hope it's okay to add that I'm also concerned about the nursing culture broadly and its effect on trans people's health and safety. I'm quite aware myself, and I have to say I may sometimes be guilty of it, of the kind of gossip or sarcastic comments that nurses might make in private about a particular patient. And it worries me that such a kind of disrespectful discussion of a person's trans status also forms one layer of the dangers that trans people face in their encounters with healthcare. And for me, personally, awareness that I myself might be discussed in such a fashion is genuinely one of the barriers I face, and sometimes without success in terms of overcoming my own sense of reluctance in contemplating the healthcare that I need. Finally, in this regard, too, in terms of safety, competent healthcare, and so forth, culturally competent healthcare, it has occurred to me that it would be great to have trans advocates in the healthcare agencies and healthcare systems. I've noted that, for example, sometimes that First Nations people are offered the support of a culturally sensitive advocate to help them through their healthcare experience in hospitals or elsewhere. And I would personally have liked at times to have advocates in the same way for trans patients, myself or other people I've encountered, who can often be very vulnerable in conventional healthcare settings, or who simply may avoid accessing healthcare in the first place because they just can't face the challenge of self-advocacy in a situation where they fear at least indifference, if not outright hostility. And then a few other quick points. In community healthcare, of course, we've noted already the degree to which LGBT people in general may well fear stigma and a lack of sense of safety, and therefore may not have equal access to family doctors or nurse practitioners, particularly, as Zach was noting, in small town or rural areas, but it can be an issue in larger areas too. In terms of sexual health, we've talked a bit about some of the concerns for youth. It is worth noting such things as the idea that trans men can get pregnant even when they're on testosterone, and trans women may be fertile even when on estrogen. So we need to think of those in terms of contraceptive advice. We've noted that a higher percentage of LGBTQ in general, youth, do not engage in safe sexual practices. This is certainly true for trans youth. Trans youth also, counterintuitively, have been shown in the U.S. to have higher levels of teen pregnancy or involvement in teen pregnancy than non-trans teens, which seems, again, counterintuitive, but apparently is actually so. Again, et cetera. So again, there are particular issues to sexual health and sexual safety that we need to consider in relationship to trans and broader LGBTQ youth. Then a concern that's very much on my mind, since I'm well into my middle age, that I wonder about the role of geriatric nurses with the care of trans people and the idea of trans people and aging in general. It seems to me that there's virtually no biomedical research out there about what it is to be transgendered and aging, the effects of exogenous hormones on the aging process, whether we should be titrating these hormones to the age of the person, whether the maintenance of useful levels of hormones might be harmful to us, or for that matter might be beneficial. Maybe we've discovered the fountain of youth, and so forth. And then again, too, in terms of psychosocial health and aging, there are also a lot of concerns that trans people have in that regard. There's very few social services, old age homes, or communities that have considered trans seniors' particular histories. It's worth noting that these people in particular, given their long history and times of great levels of prejudice, have probably suffered extraordinary extraordinary levels of stigma and shame and self-concealment, and that affects the way that they continue to view themselves and their health care. And then, two, we need to consider what their current needs and security are. Is it safe for a trans person in an old age home to be known to be trans? We hear about elder abuse as a broad problem. If a person is more likely to have suffered transphobia or homophobia, does that increase the likelihood of elder abuse and so forth? And then again, we noted finally in terms of street nursing and dealing with homeless population, that LGBTQ people in general and especially youth are particularly prominent in that population. And my experience with street nurses is that they're already well aware of these issues. But again, trans people like LGBTQ in general experience high levels of poverty, higher levels of mental health issues, higher levels of addictions for all of the reasons that Zach was already mentioning. So these are some of the questions and concerns that I've thought of in regards to trans people and healthcare. I think Zach is going to carry on with at least some basic suggestions around what we can be doing as nurses to improve our capacities here. Zach, are you there?
I am. I thought I was starting on slide 15. I think this one's yours as well.
I hope I've covered what I was supposed to. Sorry. I guess I should have just mentioned this. Then the basic piece of advice, of course, is that one should engage in education and training around trans and LGBTQ health issues in general. That it behooves us to try to educate ourselves, however little or much, but at least to become culturally competent. So these icons here demonstrate some of the places you can go to for information in regards to transgender and LGBTQ healthcare. Specific information on things like hormone therapy and surgery, for instance, advocacy, and so forth. So these are some of the agencies that one can access and websites you can access. It's also interesting just to note the BC Children's Hospital there. There's a lot of information that they offer, their website offers around trans children as well, who again are oftentimes not very visible and whose needs are, of course, very specific as well.
Great, thank you, Derek. So with lightning quickness, I'm going to go through just a few points of how we as nurses can change our approach, and just some things to keep in mind. So and this kind of all plays off what Derek was speaking to about the nature of sexual identity and expression and sexuality and the non-binary nature of it as well. So, I mean, and this is largely a criticism of our forms in hospital. I mean, we have, what is your gender, male, female, or there might be a T there for transgender, but honestly, what I've heard from some trans people is that it would be best if we had an open-ended question in order for them to identify their gender in their own words. So we should be mindful of our forms, certainly our signage. There is a movement to change our washrooms to be non-binary. Certainly, when it comes to pronouns, particularly when you're addressing a trans patient, ask what pronoun. This is what I do. What pronoun would you prefer I use? And then I'll hear he, she, or they, and then that's the one I'll use. I think it's a respectful question, and that's how you can start. As Derek noted, if you make a mistake, it's not the end of the world. Treat it like you made a mistake with somebody's name, or you bumped up into somebody in the hall. Oh, sorry, and then move on. Don't make assumptions based on sexual identity or sexual orientation or gender identity based on somebody's appearance or what you perceive their sexual practices might be. Keep those open-ended. Ask, do you have a partner? Instead of presuming that they are heterosexual and that you're, naming wife, husband, boyfriend, girlfriend. And avoid, and I think this is particularly for trans people, avoid asking questions that are not relevant. Unless you are the patient's family practitioner or their trans care provider, much of the information about the details of their gender are not really relevant. You capture it in your medical history, your medication history, to pick up any hormones that inform your why somebody is in emergency or whatever point of care they are in, and a surgical history will reveal the rest. And if it's not there, then it's probably not relevant to that encounter. To get into what are your plans with genital surgery, or have you had it yet, or whatever. Totally not relevant to the encounter and insulting to the person. And then the other point I would make about that is, I think for a lot of trans people, when they have a sore shoulder or a cough or abdominal pain or something, that's what they're there for. That's the care that they're seeking, for the history for the treatment to go through this filter, this trans filter, for any ailment. I think is shows a lack of caring as well. And I'll also comment that this sensitivity should extend to the families of LGBTQ people as well. For instance, a patient who is the child of a trans person may also struggle to disclose their parents' trans status when discussing familial medical history. So we need to work on creating open and inclusive healthcare environments, and so there's been a lot of work on trying to identify our spaces as being LGBTQ safe spaces. ARNBC recently became a participant in the Safe Space program. This is run by the Vancouver Police Department, and it identifies offices or businesses that are designated as a safe space. But I think we need to take a step further in our healthcare environments. It's most health authority policy that emerges be LGBTQ safe, but I personally think it doesn't hurt to add the decal to most points of care and most clinics. Whether you think they have something, if it's a heart failure clinic. And why shouldn't that be a safe space clinic as well? I'm in favor of pushing harder and perhaps overshooting on our advertising our inclusive and welcoming environments. Let's just move along. And so, lastly, what can we do? What can we do as nurses against these stereotypes and discriminatory policies? And we've spoken of some of the systemic changes that are needed, but a lot of this is at an individual level. We change our approach when talking to people. We keep these things in mind. At the organizational level, we can advocate for policy and procedure changes that foster supportive environments. As a profession, nursing knows full well the importance of human rights and health equity. And so if we want to be champions of that, we must speak out against discrimination that occurs at all levels, be it organizational or personal. Be an ally, and an ally is simply a heterosexual and or a cisgendered person who supports and celebrates these queer identities and will actively interrupt and challenge queerphobic and heterosexist remarks. So when you see it in the workplace, call it out. I mean, you don't have to make a big deal. Just say that I'm uncomfortable with that. Do we have to, talk this way, or do we have to, look at the world this way? And those subtle efforts will, slowly cause others to explore their own biases. And so we do want to leave room for questions. So, this slide is just to encourage you to explore your own attitudes and beliefs around LGBTQ people, and look within yourself. Is there an uncomfortability when working with LGBTQ plus patients? And if so, why? And do you require any more education? How can you transition yourself into an ally and a champion?
All right, thanks so much, Zach and Derek. So we do have about 10 minutes for any questions or comments. For those who called in or logged in after I made the announcement, you are all muted. So if you want to make a question or comment, there's a sidebar on your right-hand side where you can type in a question. And I'll give you guys a few minutes to do that. And if there are any, we can read it out loud, and hopefully Zach and Derek or anyone can comment. I don't see any questions. A lot of the comments are just to thank Zach and Derek for the presentation. There's a comment just to let you guys know that you guys provided some really new thoughts and perspectives, and they really enjoyed it. So thank you, Zach and Derek. We will be archiving this webinar on our website, so please feel free to share it once it's up with all your colleagues. And stay tuned for future webinars that ARNBC will be hosting. So take care, and thanks for joining us.
Thanks, everyone.